Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins breast reconstructive surgeons, Drs. Wendy Chen and Nima Kavanan, will be speaking about understanding the breast reconstructive ladder. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters, and the last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note, if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Drs. Wendy Chen and Nima Kavanan to begin our presentation.
All right, so just jump right into it. Okay. All right, welcome everybody. I'm Wendy Chen and Dr. Kavanan is also here. The first part of this presentation, I think, is kind of organized into three main sections. How does the cancer treatment and the reconstruction work with each other? Because they have different goals, and how one impacts the other. And how do you define your personal values and goals? And how do you reconcile that with the ladder of options that are available? Because different people have different goals. And so different options might be right for one person and not the other person. And then we'll talk about what is that ladder? What is the least invasive and what is the most invasive? And what are you getting out of it when you choose something that's more invasive? Okay, so when you have cancer, you know, it's sort of cancer first and like your health first and safety first. And so what does that really mean? Let's deconstruct that a little bit. For example, are you young and healthy and active, or are you a little bit older? Maybe you're a tea and toast kind of lady, you know. Maybe you have some existing health problems. Maybe you're on a blood thinner. So these are all important considerations when we think about how we want to approach any type of surgery. Do you live alone? Do you have many steps up and down that you have to take? Do you have a lot of support, whether friends or family or spouse or, you know, caregivers? Or do you have less people available to you that could help you in the recovery period, which can be weeks or months? What cancer surgery are you getting? Are you getting a total mastectomy on one side or on both sides? Or do you have the option of a lumpectomy? Sometimes that decision is made based on how much cancer you have in the breast that you have. So let's say you have a very large breast and a very small cancer. Great, maybe lumpectomy is the right path for you. What if you have a very small breast, but a pretty big cancer? Then it's a little bit hard to do a lumpectomy, you know. What is the quality of your skin? So the anatomy is you have skin, you have subcutaneous fat, and then you have your breast tissue. So if you are very, very thin and there's not much subcutaneous fat, how strong and healthy is that skin? How good is the blood supply after you cut out the breast itself? How much skin, muscle, and nipple is going to be taken? So this can be impacted by where is the cancer? How big is the cancer? What type of cancer? Is it responsive to chemotherapy? And what has to be taken to, number one, safety, what has to be cut out in order for good cancer, thorough cancer treatment? Reconstruction can be done immediately at the time of mastectomy or lumpectomy, or it could be done in stages, meaning multiple surgeries kind of spread out over a certain period of time. And then the reconstructive surgeon is always thinking about radiation because radiation can really impact tissue quality. So going back to the skin, the muscle, these things, radiation is certainly a type of injury to that skin and soft tissue. If you're only getting radiation on one side, then it could affect the symmetry of your final result, and it could change your risk profile and what options you might want to do. So when we talk about your goals and values, what do I mean by that? So some people, some ladies, they say, I just want to look symmetric when I'm out and about in clothes. That's all I care about. I don't need much. And some people say, I want to look like I did before surgery. Nipples, the breast mound shape, my size. That is what my goal is, as close as we can get to looking like myself before cancer. How much surgery do you have an appetite for? Do you have a tolerance for? Do you want to do both breasts, one breast? Do you have very young children? Do you have a very demanding job? Do you want to get right back to it as quickly as possible? Maybe you're a elite athlete, you know, or do you have time to just slowly do, as we say, staged recovery or multiple donor sites, meaning you operate on one breast, maybe two breasts, maybe you have a donor site from your belly or another part of your body, and you have the time to commit to that, to invest to that. I've already touched on donor sites. So every time you operate on somebody, you are introducing a risk and complication profile. You know, sometimes the risk is very low, but you still have to talk about it for informed consent. So if you have another donor site, then there's another location, another surgical site where you have to think about potential complications or side effects. And how do these options reconcile with your baseline health? Let's say you got heart problems, lung problems, liver problems, maybe a really short recovery and the most minimal operation is the right operation for you. And then if you, there's two main categories. One is breast implants, and one is using your own tissue. So sometimes people call that autologous, auto like self. So if you choose implants, you know, there's maintenance. I say to people, it's kind of like a car every 10, 15 years, you know, you gotta maybe switch it out. So if you're very young, maybe you say, oh, I don't want to do like a surgery every 10 to 15 years, even if it's a very small surgery. Or you may say, I don't want to do the maintenance and surveillance, which is an MRI scan every few years. I just want to do it and forget about it. And then, you know, as surgeons, we talk about, you know, you take on a certain amount of risk. Well, what are you getting out of it? What is the benefit? And so that's something that your reconstructive surgeon can talk to you about. So going back to the vocabulary, autologous meaning your own tissues or implant based, okay? So this is just a picture that shows some of the areas that we can get donor tissue from if you choose that route versus putting an implant under your skin, which is shown in green here. Most of the time when surgeons talk about autologous, they're talking about flaps, and that's this option number 3 and 4, flaps, where we take a piece of your belly or your back or even other places, as that picture showed, and transplant it, so to speak, disconnect it from its donor site and put it somewhere new with microsurgery, or rotate it from your back. But you could also potentially, if you have a very modest goal in terms of size, you could potentially use processed fat if you have enough fat. Implant-based, breast implants, I'm sure people have heard about silicone versus saline. Sometimes when it's possible, we can go direct to implant, DTI, direct to implant. But sometimes if we need to put a placeholder in there, that's called a tissue expander. And that's when, let's say we want to expand a little bit more tissue, get a little bit more skin out of it to put in a larger implant, then we do that. And sometimes we use something called a dermal matrix, and it's just that it's kind of like an infrastructure, like a support that we can sew in to sort of support the shape and placement of the implant. So in plastic surgery, we talk about the reconstructive ladder. And what that just means is, what is the least invasive thing that we do versus the most invasive? So if you're getting a mastectomy or a lumpectomy, the least invasive thing is to do nothing and close you back up, maybe rearrange the tissues a little bit so that it looks nicer. But some ladies, there's certainly a movement called going flat, and you could go flat. Some people do very beautiful tattoos, artistic tattoos over their chest once they do that. And that's the right choice for some ladies. Some ladies just use a prosthetic. So it could be built into the bra, or it's something they use to fill out the bra. That's certainly perfectly fine. And as you can imagine, there's basically no surgery involved in that. We just close you up nice. And then this is doing a tissue expander or an implant. So in this picture, you can see that the sort of orangey color is skin, and this more reddish color is muscle or fat. And so, you know, depending on your personal situation, sometimes we put it under the muscle, sometimes we can just put it under your skin and fat. For example, in a very, very, very thin person with very thin flaps and skin after the breast has been cut out, we may consider putting it under the muscle. Or if you're extremely active and muscular and you don't want the implant to move every time you animate your muscle, you might want to do it on top of the muscle rather than under. This needle shows that when you have a tissue expander, we basically progressively over time fill up the expander to the volume that we're wanting to be. And then the next stage would be to put the final permanent implant in there. But we use a magnet to find the port, and then we put fluid through the port in clinic. And it's a very small procedure in clinic that we do weekly or so until we fill you up to the volume we want. And this kind of touches on that above, below the muscle, sometimes using a tissue matrix to shape the pocket. And again, depends on how thin the skin and soft tissue is and whether radiation is happening as part of the cancer treatment. Sometimes people say, should I do silicone or should I do saline? So technically, silicone implants are for people age 22 and plus. Generally, people like silicone because it can feel more natural, and there's less wrinkles in it, called rippling, especially when you have no breast tissue anymore covering up the implant. The downside is that if the device fails, aka it ruptures, that's why we need MRIs to know that it has ruptured. And so implants are not meant to be lifetime devices. They're meant to be, hey, after a certain degree of time, we need to kind of switch them out because it is a foreign body and it's not meant to be in there forever. Saline implants, you could potentially have a smaller incision in the future when you do changing out the implant every few years. But if you're really thin, there can be some wrinkles. And what I mean by that is, like, silicone it could hold its own shape, but with saline, it's just water. So the shape is really just whatever is inside the water balloon. But if you put a silicone implant on the table, it has a mound sort of shape that it can kind of maintain depending on how cohesive it is and how firm and how it's maintaining its own shape based on the consistency of the silicone inside. As we talk about ruptures, when you have a saline implant, you know if you're ruptured. It's just a water balloon and the saline goes into your body and your body absorbs it, and it's very obvious and you'll know. But with silicone implants, you kind of usually need some imaging to potentially help you figure out if you're actually ruptured. All right, I'm going to turn it over to Dr. Havanin here to talk about some flaps.
All right. Thanks for the intro, Wendy, and nice to meet everyone. My name is Nima Kavanen. I am a plastic surgeon here at Sibley. Like Wendy, we both offer a full range of breast reconstruction, all different types, and we're happy to talk to anyone who is interested in more detail about their individual case. But my extra training I did after plastic surgery was in microsurgery. So I have a small bias towards doing flaps because I spent an extra year of training dedicated to kind of learning these flaps and figuring out how to do them efficiently and effectively. And so I'm going to try to give you an objective presentation today of all the different options, why you would consider a flap. I think it's a reasonable option to chat about for all patients, and then depending on your individual situation, your life, your goals, for some people it ends up being a good option, for others it doesn't. So, as you can see here, when we talk about flaps, there are two options, regional flaps and then free tissue transfer. And we'll chat a little bit about both of them. But the elephant in the room is that, as you can see here, you're starting to approach pretty high on the reconstructive ladder, pretty high in terms of the complexity of the case. So why would anyone ever want to do something so complex when we have much simpler options available? And I think there are really three scenarios or three reasons why patients tend to choose autologous options. I think the first is that they want to try to avoid an implant. And Wendy will talk a little bit more about complications. She already alluded to a lot of the issues with implants. They're not lifelong devices. They're not permanent. And, if they were perfect, we'd use them for everyone. But unfortunately, they're not. And so for a lot of people, we want to try to avoid implants. They want to try to avoid implants. And so this is an alternative that we can chat about and might be good one for them. The second is that I think some patients tend to like the idea of using their own tissue, even beyond avoiding implants. We've done a lot of research on patient-reported outcomes with all kinds of breast reconstruction. And one of the things that we have found is that all patients in general tend to be pretty happy with their results. But in the long term, and we're talking maybe like 12 to 15 years out, patients who use their own tissue may have slightly higher satisfaction rates than those who use implants. And we think the reason for that is just one, you're avoiding all of the maintenance that goes along with implants. You don't need to worry about screening. You don't need to worry about replacing them. And two, your reconstruction is using your own tissue. So it's your own fat. It's a part of you. As you change over time, your breasts will change over time with you. So if you gain a little bit of weight, if you lose a little bit of weight, everything will stay proportionate. And because it's your own tissue and not a prosthetic device, it kind of ends up looking a little bit more natural in the long run too, especially when you're looking at yourself outside of clothes. And the third reason to consider your own tissue is in kind of more complex and niche cases of breast reconstruction. Maybe patients who have previously had a lumpectomy and now have a recurrence and have had radiation. Maybe in patients who have special types of breast cancer that require removing a lot of skin along with the tumor. Or in patients who've had complications with previous options of breast reconstruction. Maybe they've had an infection with their implants, and maybe they've had to have their implants removed at some point. So there are some cases in which medically it's kind of a safer and better alternative to using an implant. And so as Wendy alluded to, there are a lot of different options for areas where we can take the tissue from, and I'll try to briefly touch upon all of them. But the gold standard, I think the first line for almost any plastic surgeon anywhere in the country is going to be using the abdomen. And I'll touch upon that a little bit in some of the future slides. I think in terms of using your own tissue, the simplest way to do it is to keep that tissue attached to its blood supply via a little stock. In order to do that, we'd need to bring that tissue around from somewhere nearby the breast. So typically with these regional flaps, we can either keep the tissue from the abdomen connected and tunnel it up into the breast, or we can keep the tissue from the back connected and slide it over into the chest. This is called a tram flap in the abdomen or a latissimus flap in the back. The biggest downsides of these procedures are one, obviously you're going to have a totally separate independent surgical site. We're going to have to make incisions on your abdomen or your back. And two, in order to keep the blood supply connected, we need to take some of the muscle with us. So when we're doing a latissimus flap, the skin and the fat that we're transferring stays attached to the latissimus dorsi muscle, this green muscle here in this picture. This is the muscle that we use for pull-ups. So for most people, and myself included, I don't do very many pull-ups. We're not going to miss this muscle being gone on a day-to-day basis. But at the end of the day, if we can avoid it, it may be better to leave the muscle there and can cause fewer functional issues in the long run. With the abdominal option, the tram flap, the skin and the fat ends up being attached to your rectus abdominis muscle. That's the six-pack muscle running up and down the middle of your abdomen. This can have a lot bigger consequences if we take this muscle. That your core is very important to a lot of activities, sitting up, standing, coughing, walking. We're always using our core, even if we don't realize it. And so removing this muscle can cause a lot of pain in the abdomen, can cause a lot of soreness, and in the long run, it could put patients at risk at developing bulges and weakness in their abdomen and their core. And so, this is an option that we still use in rare scenarios, but this tram flap has really kind of fallen by the wayside. And so, if we're going to use tissue from the abdomen, we try to do something a little bit more sophisticated that can minimize these complications at the belly for patients. And this is where the idea of a free flap comes in. So as opposed to these regional flaps where we're keeping the blood supply connected via some stock of muscle, with a free flap, we just disconnect the blood supply and reconnect it somewhere else. So in the case of the abdomen, we don't take the muscle anymore. We just dissect the blood vessels through the muscle, chase them down to where they start in the pelvis, and then we clip them there. We transfer all of the skin and the fat up to the breast, and we reconnect those blood vessels to little blood vessels that run on either side of the sternum, called the internal mammary artery and veins. So this is, I think, has been a huge step forward in terms of minimizing complications for patients. That muscle is still there. It's still going to work. You're going to be sore still after surgery, and it's still a pretty big recovery just because we're cutting through that muscle, causing trauma, causing inflammation. But once it all heals, patients tend to do a lot better in the long run. There's still a small risk of bulging at the belly just because we're cutting through that muscle and we're kind of traumatizing a little bit, but it's usually in the 4 to 5% range in the long run, much lower than the tram flap alternative. And the shape of the breast reconstruction is the same, which I think is the most important part and one of the best parts of this deep flap or this abdominal reconstruction technique. Can you go back one more slide again? Sorry. The downside of this obviously is that, we're adding a little bit more complexity compared to the regional flaps. That's why it's a step higher on that ladder, because now we're disconnecting the blood vessels, reconnecting them. And one of the most dreaded complications, the things that we are super vigilant about postoperatively to try to avoid, is forming a blood clot where we reconnected those blood vessels. And so when I do these for patients, I'll keep them on aspirin for at least a week. I'll keep them on a stronger blood thinner, usually a shot or a pill, for sometimes up to a month, depending on their individual risk factors. And we watch you very carefully in the hospital for 2 to 3 days to really make sure we're getting good blood flow and we're not forming blood clots. So there's a lot more upfront investment with these autologous or tissue-based procedures and a little bit more of a recovery in terms of activity restrictions, just time off of work. But in the long run, I think for patients who are motivated to get them done, I think you'll get an excellent result. And patients tend to be very happy with these reconstructions. Now, why do we use the belly? Well, I think the main reason is that most people tend to store a reasonable amount of extra skin and fat in the abdomen. And so it's just a good area where we can take enough tissue to make a reasonably sized breast reconstruction. Now, for some patients who have either maybe had a tummy tuck in the past or just kind of very thin, skinny, don't have a lot of extra tissue, there are other places that we can look to. The thighs are probably the inner thighs are probably the second most common area. And then there are kind of more esoteric and rare situations where we can use tissue from the buttock, tissue from the lower back. Each of these has a little bit of a difference in the risk-benefit profile, especially with the thigh and the buttock. Nowadays, patients are very, a lot of patients like to have a little bit of extra tissue in the thigh and buttock. They don't want to be totally flattened and kind of, get rid of that extra volume that they have there. And so, I think it's when we're starting to think about areas outside the belly, it starts to become a much more individualized conversation about what the patient's willing to tolerate, where they have enough tissue to give, and how large of a breast reconstruction we can achieve with that tissue in order to kind of figure out what works best for that patient. Right. And we can go to the next slide. And so, I'm sorry that was a whirlwind tour on a very complicated topic, but hopefully that gave kind of a good overview of at least what's out there. There is one other exciting topic I wanted to bring up just to put on everyone's radar, and that's this idea of nipple reinnervation. And this is something that's been really just developed over the past maybe 1 or 2 years. And I think Wendy and I are excited to be kind of bringing it to Sibley and offering it to our patients. And it kind of tries to address this problem with nipple sparing mastectomy. in that, we go through a lot of effort, or the breast surgeons go through a lot of effort to try to save the nipple with a nipple sparing mastectomy. But in reality, that nipple really serves no function after you save it. Clearly, the ducts and all of the breast tissue are gone, so you're not going to be able to lactate or produce milk anymore. But even other sexual functions, such as kind of nipple sensation, nipple stimulation, are not going to be relevant anymore because all of the nerves to the nipple get cut during mastectomy. So it's a completely insensate nipple that really doesn't do anything other than serve a visual aesthetic purpose. And so we've started thinking about ways, well, how can we try to restore that sensation to the nipple? And the coolest thing about this is that from a patient standpoint, what we do doesn't really, you're not going to notice when you wake up necessarily. It's the same incision, same recovery. It just adds about 45 minutes of surgical time to each breast. But we're able to use what's called a nerve graft, which is kind of an off-the-shelf product that helps to bridge a gap that was cut in the nerves. And we're able to restore the continuity of those nerves that were cut right next to the pectoralis muscle on the chest. And we reconnect them to the areas where they were cut on the underside of the nipple on the breast skin. And now you can go to the next slide, Wendy. So, does this work? I guess that's the first question that comes to mind. And, this study I kind of cited here on the side, I don't mean to get lost in the weeds here, but this is a study where they compared patients who had this procedure done to those who did not, to control patients who had never had a mastectomy. And the main thing that they measured was how sensitive the nipple is. How much pressure do we need to apply before a patient's able to tell that we're touching their nipple? And you can see in this very last column here, the mean amount of pressure was 0.07 grams. So very, very small amount of pressure, and patients were able to detect that something's touching their nipple in a baseline control population. In patients who had a reconstruction, the average was about 35 grams. So higher, but much less than the average in patients who had no reconstruction, where they had about 180 grams. And if we look at the medians, we see that the median is actually much lower than the 35 grams. So the vast majority of patients are getting, really, really good sensation to touch after about 1 to 1.5 years of nerve regeneration with this procedure. And patients who aren't getting this procedure have, as expected, very poor, several hundred grams needed before they can tell that something is touching their chest. So nerves grow slowly. That's why it takes a while for this to come back. It's not an instant fix. It's not a overnight solution, but it is a very exciting option for patients who are getting nipple sparing mastectomy to be able to restore that sensation. The sensation that we think we're restoring is probably sensation to light touch, so patients can tell if something is touching their nipple, their clothes are touching it. We don't know yet whether this is going to translate into sexual function, sexual well-being yet, and I think that's something that remains to be studied in the future. But at the very least, we know we are restoring sensation to touch based on the evidence currently out there right now. What are some of the variables affecting this? Are there some patients that are going to do better than others? And the answer is yes. Radiation, obviously, as Wendy alluded to, causes problems with a lot of what we try to do as plastic surgeons. It's necessary, obviously, for cancer care, but it does negatively affect our body's ability to heal, and the nerve's ability to heal is no exception. A higher age has been associated with poor nerve regeneration, diabetes, smoking. It's kind of the usual kind of suspects that tend to increase wound healing and wound regeneration. And then some issues with post-op complications can diminish nerve regeneration. And in patients who tend to have a larger bra size preoperatively, it's a longer distance for those nerves to regenerate. And so sometimes that can affect the ability to restore sensation. And so again, thank you for your attention and thank you for your time. I'm going to pass it back to Wendy, who's going to wrap things up talking about complications.
So I grouped the complications into sort of more things that could happen closer to the time of surgery and things that may happen kind of way further down the line. So I think first thing is when you wake up, I think you should expect that you know, they were probably always siblings and not twins, and they're going to continue to be siblings and not twins for the most part. We try our best, but we don't want to. I always tell people, I'm not God, I'm not a wizard, I'm just a human surgeon with hands, you know. Acutely, we are always doing a good job to try to make sure that you're not going to bleed after the operation, making sure anything that we see during the operation, we're going to control that. But sometimes bleeding can happen that requires a return to the operating room, called a hematoma, hema like blood. You could get an infection. I think nowadays that's pretty uncommon, but any surgery, you could potentially get an infection because we violated the skin. And we often say that the nipple is dirty because it's an open to the outside world. You know, milk can come from inside to out. And so ostensibly bacteria on your skin can grow from outside to in, you know. Wound breakdown. So that means, let's say you have very poor nutrition. Let's say you got an infection. What we sewed together, it could potentially come apart a little bit or a lot. If it comes apart a lot, you could get an exposed implant. And so then we would have to definitely go back and do something to remedy that and put the implant back in a safe place, which is being protected by skin. Sometimes there's a phenomenon called red breast that people are still trying to understand, but some sort of inflammatory process that occurs from the body responding to what's happened. Nowadays, there's a protocol where you hit it with a bunch of different antibiotics and wait for it to kind of calm down. These are sort of the major ones that we think of, but nowadays I think occur really exceedingly uncommonly. But as part of informed consent, I think you got to know just in case. And I think surgeons will contextualize that for you. Let's say you're very thin, you have diabetes, you got to get your cancer surgery. And so what is your risk? If you're smoking and we got to do your cancer surgery, we can try to mitigate those risk factors, but your risk might be a little bit higher than a non-smoker. You know, when you have radiated skin, that can increase your complications of the ones we just mentioned. Seroma is when your body doesn't know when to stop making fluid. So you skin your knee, you see that like golden crust, that sort of chicken broth that comes out. On a bigger scale, this happens when you get breast cancer surgery. So for example, you know, the incisions might be small, maybe a thin line, but where we operated is the whole, almost pretty much the whole chest, right? And so your body sees that as where it got traumatized, and sometimes it just makes fluid. So after surgery, oftentimes people have drains, little tubes that go from inside your body to outside so that fluid can drain out. But sometimes the body just doesn't stop making that fluid. And sometimes we have to treat that medically or surgically. Implant rupture, we already talked about. Every year that implant is in your body, it increases a little bit of risk that the device is going to fail. Okay. And then capsular contracture, I think, is something that can be really irksome and troublesome and challenging, but certainly doesn't happen to most people. And it just means that your body sees an implant. An implant's a foreign body, and so it forms a capsule, it forms a scar. As in any part of your body, you know, you might see that the scar is oftentimes a little bit firm and raised, but over the course of about a year or two, it really flattens and softens, and then it's kind of like your own skin again. Sometimes there's sort of a pathologic abnormal scarring response around that implant, and it continues to get harder and harder until it becomes maybe a little bit painful, uncomfortable, or until you can see it kind of like contracting the breast and the implant. So that's capsular contracture. And again, it's been researched a lot. I don't think it's totally figured out yet, but what we know we can do is to try to be really OCD clean about it when we're in the operating room and do our best with that. The other thing that was very hot topic a few years ago is breast implant associated lymphoma. This is a very, very, very rare complication, but because lymphoma is a scary word, it's like a cancer. And so we want to tell people about it. It's associated with textured implants, which are no longer on the market. And if you have a textured implant in your butt, you could get butt implant cancer, so to speak, like lymphoma. That's been reported. Now that we know about it, it's high alert on every reconstructive surgeon's mind. And so if somebody says, hey, suddenly I have fluid again, suddenly I'm having these symptoms, we know to go and look for that fluid, take it out and test it to see if it's this. And if it is, we remove the implant and the capsule. And if we need to, these adjunctive treatments, chemo, radiation. But I would call this an exceedingly treatable lymphoma. And this is data from when it first started happening. And I would say the data is probably better now. But that remains to be published and discussed at the national level. But exceedingly rare, exceedingly treatable, but we want patients to definitely know that this can happen. And again, the textured implants that it's most associated with are no longer sold, used. And I think they even went and told the patients that had them, that had textured implants, hey, let's get those out of you and put a new implant in you. And then in terms of nipple reconstruction, if your cancer surgery required removal of the nipple and you desire a nipple, from a aesthetic standpoint, I don't want to use the word ornamental, but sort of something to make the mound give you visually, that's a breast. You could do tattoo. You could do this sort of prosthetic, which is shown here on the top. You could do an anatomic tattoo, which there's some specific 3D tattoo artists that specialize in nipple tattoo that can make it look better than any tattoo that I can make as a surgeon. Or some people do something very artistic and non-anatomic. And then the last option is flaps. And it's not quite the flaps that we've been talking about. They're very small little flaps that like you kind of origami the skin that's there into something that looks like a nipple. But surgeons don't love these flaps because admittedly, they don't always stay projected. Sometimes they flatten out with time. And we wouldn't call it a home run surgery, but sometimes people want to give it a try and see how they do with it. And we can certainly offer that. Okay, that is a whirlwind tour, as Dr. Halvenine said, and we are happy to entertain any and all questions. These are the instructions again for submitting a question with your name, without your name, through an email. And so let's entertain some questions.
I do see one question in the chat. Will my nipple ever feel like mine again? Yeah, that's a great question. Those last techniques that Wendy touched upon for nipple reconstruction are purely aesthetic. So for patients who've had their nipples removed and they either get a tattoo or a little flap procedure to make a little nipple mound, that's purely visual. It's not going to have sensation. It's not going to have any function. For patients who have nipple sparing mastectomies, with the nerve reconstruction, what we find is that, usually by about 11 to 12 months, when the nerves start to grow back into the nipple, they'll start to get some sensation. And, they'll be putting their clothes on, they'll feel something touching their nipple. And by, 18 months or so, that sensation will have continued to get stronger and solidified. And, I think at that point, it'll kind of be the same sensation of, hey, something is touching my nipple, something is, rubbing against my nipple. We don't quite yet know if that relates, how that translates to the sexual part of it. And obviously that's an important consideration. But it definitely will feel like your nipple when something is touching it, if you kind of put your clothes on and off. And so in that regard, it's definitely a big step forward. And I think patients have been pleased to kind of be able to have that experience as opposed to just being totally numb on the chest with no reconstruction.
In terms of which do you typically recommend, your own tissues or implants, I think that's a really personal decision based on some of the criteria we've mentioned. And I say to people, you don't have to buy the car today. You can go home and think about it, talk about it. We can come back and talk about it again, because I don't expect people to absorb 100% of the information we tell them. Obviously, as you can see in this presentation, it's a lot of information. And sometimes people go back out with the information we give them and like talk to people on their Facebook groups and their peer groups, and that helps them to formulate. Sometimes I tell people, just because you choose an implant for your first reconstruction doesn't mean that, let's say in 10 years from now, you're like, I don't want to keep doing this implant out, implant in thing. Can I go for an autologous reconstruction now for my second one? And you can definitely do that. So that's an option. If you don't choose it right away, you can still choose it later. But I think from a nerve standpoint, that's most easily done at the time of the mastectomy. It's hard to find a nerve through formed scar and capsule to try to put that back on. And from a receptive standpoint, the nerve endings that were freshly cut during the mastectomy, you can't really kind of connect it sort of 10 years down the line. That's not really something that we can do with current science and technology.
Yeah. And I definitely agree with Wendy. It's definitely a very personal decision, and there's no one right answer for everyone. Some people come in and they know family, friends who've had one form of reconstruction or another, and they're set on that, and that's great. I think for other patients, they have to think about it a little bit more. I think one benefit, when Wendy touched upon this, of the tissue expanders, is that, a lot of times when I'm doing breast reconstruction, I encourage patients to do it in stages, in 2 stages, to get a tissue expander at the time of mastectomy. And then down the line, we can swap it out for their final implant or final reconstruction, whether it's implant or their own tissue. And that gives them time to kind of go through the experience of the mastectomy, because many of these patients haven't had surgery before. They don't kind of really know what to expect. And so they'll see kind of how the mastectomy affected their lives, how that recovery went, whether they want to do something quick and easy for the next surgery, whether they're willing to go through a bigger, more extensive reconstruction using your own tissue. And then it also kind of gives us time to think about some other things like radiation, which I see someone asked a question about. So we'll talk about that a little bit more in a second. But I think both options are great. I think patients are generally happy with both. And it really comes down to, what your activity level is, what your life is like. Are you willing to take, a month or so off of work to not use your core muscles for 3 to 6 months after surgery? Or do you just want to get back to the gym as quickly as possible, get back to work as quickly as possible? Do you have kids at home that you need to kind of, pick up, carry them around? So it's definitely a very individualized decision. And I think the good news is that at the end of the day, most patients tend to be happy regardless of which one they choose. I guess I can jump into the next question really quickly too. So having double mastectomy, how does previous and future radiation affect options for my reconstruction? So those are, I'll start with previous and then we can chat about future too. I think previous radiation affects the options much more so than future radiation. When tissue gets radiated, it gets very firm and scarred and just a lot less pliable, a lot less stretchy. And so when we think about using an implant or a tissue expander, if you put a tissue expander under radiated skin and you try to inflate the tissue expander and stretch out that skin to be able to hold a bigger implant, that radiated tissue is just not going to stretch out. And it's also kind of beat up a little bit from the radiation, scarred from the radiation. So you're also at risk of wound healing issues, more so than your average patient, just because your incisions are more likely to kind of not heal as well. You're more likely to get an infection. And so I think in patients who've had previous radiation, there's a very strong kind of medical reason to consider using your own tissue. Now, it doesn't have to be a big, complex free flap from your belly. That's where the latissimus procedure, using tissue from your back, can be a great option. That's only a one-night stay in the hospital, relatively quick recovery. And we typically have to combine that with an implant. But now, since we're using the tissue from your back, we're mitigating a lot of these downsides of radiation, and we're able to give you a good reconstructive result with only slightly more recovery time than just using an implant. And so previous radiation definitely does affect the way I think about the risks and the benefits and the way I consult patients on them. Future radiation, I think, is less of an issue. the main thing is we don't want the final reconstruction to get radiated, because radiation can cause a lot of scarring. It can distort the appearance of the breast. So if we were to do a flap and then you get radiation to that, that flap tissue is going to get really hard and scarred, and it can get distorted. Same with an implant. So for a patient who is either definitely getting radiation post-op or a high risk of getting radiation post-op, I strongly encourage them to get that tissue expander at the time of mastectomy. That way, if they do need radiation, we can radiate the tissue expander, not their final reconstruction. Then we can, once they're done with radiation, once they've healed, we can swap it out for the final reconstruction, and we can kind of do any little revisions and do any touch-ups that we need to kind of start to mitigate the negative downsides of the radiation at that exchange procedure.
The other thing is, if you, for some reason, your chest has been radiated in the future, it does make any microsurgery a little bit more difficult to do. Even the vessels, the very small blood vessels, they know that they were radiated, they feel different, they look different. It's a lot more challenging. So in terms of doing microsurgery and like taking, let's say, belly tissue and putting it onto the chest, as a surgeon, I don't love to operate on radiated microvessels. If you have a flap procedure from the abdomen, are you still able to get pregnant in the future? So let's say you've had a invasive tram flap and that six-pack muscle is gone. That would be a safety question from like the standpoint of, from obstetrics and maybe even general surgery, because you are certainly at risk for like a hernia or a bulge. I mean, could you get pregnant? Yes, I think your uterus could grow a baby and keep a baby. But from a safety standpoint, that certainly would be a challenge. I've taken care of a lady who, had no rectus muscles in the center. They were way off to the side. And she got pregnant through IVF at a very elite fertility clinic. And her uterus started to erode through, they had skin grafted her belly, and you could see her intestines through the skin. This is a little bit too much, but so can you bring a pregnancy to full term? She went on bed rest, but there's a lot that's possible medically. So I would say, even when you have that tram flap and you've taken a muscle, you can still get pregnant, but certainly you'd be a higher risk pregnancy. If you just get the DIEP flap, I would say yes, your skin will still stretch out sort of, slowly, because it's not a fast stretching out of your skin when you're pregnant. Yes.
Yeah.
Anything to add?
No, I was gonna say, I totally agree. If you're considering the possibility of getting pregnant, I would highly recommend doing a DIEP flap so we can leave that muscle behind. And then, I think there would be a slightly higher chance of possibly developing a bulge. Typically I say 4 to 5%. It's hard to give an exact number for this scenario because it's not a very common one, but maybe on the order of like 10%, maybe slightly higher. And then, one of the added benefits, one of the silver linings of doing a DIEP flap is that when we remove that extra fat and tissue from the belly, it's almost like a mini tummy tuck. And so if you get pregnant, obviously the skin is going to stretch out. It's possible that you get some loose skin again. So that kind of, silver lining benefit to the belly of tightening the skin will be undone by getting pregnant afterwards.
Yeah. But I think you could still safely get a C-section. Like, it wouldn't make it unsafe to get a C-section in terms of delivering a baby. When you still have your abdominal muscles intact, you could certainly push out a baby, but it's certainly a conversation with your obstetrician. And since we're talking about C-sections, Dr. Nima, do you want to talk about C-section and doing a DIEP flap? People who've had previous C-section?
Yeah. So, in my experience, like 99.9% of patients who have previous C-sections can get a DIEP flap, no problem. I try to use your previous C-section incision when I'm designing the DIEP flap, so that we just basically extend the C-section incision to your hips on either side, rather than creating a new incision somewhere else. For all my patients, whether or not they've had a previous C-section or not, before we do a DIEP flap, I send them to get a CAT scan of their belly. And this looks at the blood vessels that we need to disconnect and reconnect to make sure that they are there and are healthy looking and that we're able to do the procedure successfully. And that CAT scan becomes particularly critical because in very, very rare cases, maybe 1 in 100 or even fewer, the C-section will have injured one of those blood vessels, and then we'll have to kind of think about alternatives.
Okay, gallbladder scar.
Gallbladder. I've done abdominal free flaps in patients with gallbladder scars, and there typically has not been any issue. And that's again, I would get a CAT scan, and if for whatever reason there's some freak thing that happens that caused an injury to those blood vessels, we'll be able to see it. The one procedure where I've seen issues more commonly are appendectomies, just because the incision for an appendectomy is sitting right around where those blood vessels tend to live. But gallbladder incisions are way far away from where those blood vessels live. So
especially when they're laparoscopic these days.
Yeah. Sorry, I didn't read that question, but that last question was, if I have a scar from gallbladder surgery laparoscopically, does this affect my chances of a flap?
Can I use my own tissue for reconstruction in a year or more if I go flat at the time of double mastectomy? So I think if you have a it's kind of depends on your delta that you're asking for, right? So let's say you went flat at the time of mastectomy, and now you're like, I just want like an A, versus now I want a double D. That those are different reconstructive goals. And then, so for example, for somebody who is asking for a really modest result, that could potentially be a little bit of fat grafting, a little bit. Fat grafting, generally we say 50% retention. So let's say we graft, 200 cc's, a large A cup small plus, right? Like, maybe half of that, sometimes 80% is retained. So you could potentially do a few rounds of that. If you have not enough skin and you're asking for a big size, you may have to do tissue expander, or you may have to get that skin from a flap instead of growing it, sort of expanding it. And depending on if you've been radiated, how much will that skin expand? You might just need it from the flap, from the skin from the flap. But yeah, I think the answer is yes. You can always go from flat to something, but it's a very individualized consideration, both basically your goals, your anatomy, and then the surgeon kind of interprets that and tries to make the right path for you.
And just to echo Wendy's comments, I totally agree. You can go from flat at the time a mastectomy to a reconstruction down the line. And I think the preferred option would be to use your own tissue in those cases, just because, as she alluded to, you need to bring in some skin from somewhere else to make up for the fact that you don't have any extra skin on the chest anymore, since we went flat at the time of mastectomy. And that's where the flap comes in. We can either bring in some skin from the back or from the belly. And sometimes we'll have to do something in combination with a tissue expander or with an implant and a flap, but there are ways to do it. And it's kind of an individualized thing at that point. So the next question, could you touch on the S-gap, I-gap? Patient had a hysterectomy and a mastectomy and radiation. Are S-gap or I-gap possible? So S-gap and I-gap refer to superior gluteal artery perforator flap or inferior gluteal artery perforator flap. So this is using your own tissue as a free flap where we're disconnecting it and reconnecting it. But instead of using the belly, we're getting tissue from the buttock. Either the upper buttock or the lower buttock, if you do the S-gap or I-gap respectively. These are, in general, yes, they are options. How much tissue is there and how large of a reconstruction they can get is very patient dependent. The biggest downside of S-gap and I-gap, and the reason they've kind of fallen out of favor, are twofold. One, surgically, we would need to start having you with on your back with your facing upwards, just to make sure the blood vessels in the chest are okay. Then we'd need to pause surgery, flip you over, get the tissue available on the buttocks. then we need to pause surgery, flip you over, and reconnect them. So it's a long surgery, even longer than a deep flap, like 12 plus hours for bilateral. And the other downside is that, nowadays I think people are very sensitive about their buttock aesthetics, and using your buttock tissue, whether the S gap or the I gap, can flatten either the upper part of the buttock or the lower part of the buttock, and a lot of patients don't like that. So it's definitely an option for the right patient, and it's definitely something that we can do. If the abdomen is not an option, my preferred second line are the inner thighs. And again, it just depends on where the patient is storing their extra skin and fat. If they have enough tissue on the inner thighs, that would be my go-to. If not, then we could talk about the buttock. We could talk about upper back with or without an implant. Do you have anything you want to add to that, Wendy?
No, I think that sounds good. And then I think, abdomen fat is very soft and buttock fat is a little bit less soft. So just in terms of how it feels to people, sometimes I think that's a consideration.
Yeah.
What is the downtime for a deep flap?
Yeah, that's a great question. So, hospitalization wise, I would plan for like at least 3 days. I think most patients can go home on day 3. You're going to have pain and soreness and drains in the breast as well as the abdomen. And I think the biggest issue for patients the first week or so in terms of mobility getting around is going to be abdominal pain and core soreness. When we're pulling the skin down, doing that little tummy tuck to close it, patients might even have a little bit of a hard time standing upright for the first week. They're going to be walking a little bit hunched over, but eventually that'll settle out. And then I tell patients, with an implant, maybe like a week or 2 off of work and before they're kind of feeling like themselves getting ready to get back. I think with a deep flap, it's probably closer to a month, if not a little bit more, depending on what kind of work you do and how demanding it is. Before you're even getting back to light duty. In terms of using your core muscles, I tell patients I don't want them exercising anything that gets their no sit-ups, no cardio, anything like that for 6 months after surgery. Obviously walking is encouraged and that still uses your core muscle, but it's a very, very slow buildup back to actual muscles that put to exercises and activities that put a lot of stress on your core.
Yeah, when histologically, when people look at scars, I always tell people that like it takes 4 weeks to get to about 40% of strength of a scar, meaning if you really wanted to rip something apart, you could very much still do it if you did something very traumatic, or if you did something traumatic repeatedly over a certain period of time, kind of like bending a paperclip, so to speak. So I think people definitely have to have their expectations set really low in terms of what they're really going to be doing for quite a while, and have a lot of patience for being themselves again.
All right, well, it looks like that was the last question because we're running out of time, but thank you again, everyone, for your attention and for joining us. It was a pleasure.
If you have any questions, follow-up questions, we didn't get to your questions, please email hopkinsseminars@jhmi.edu in the middle of the screen there. We really love to teach. It's a part of being a physician, and I really hope that this was very informative for people. Okay.
Thanks again for joining.
This will conclude this morning's webinar. We apologize if we were not able to answer all questions. If you would still like to have your question answered, please feel free to email hopkinsseminar@jhmi.edu. We would like to thank Drs. Chen and Kavanen, and thank you everyone for joining today. A recording will be emailed to everyone within the next 2 days. If you are interested in scheduling an appointment, please call the number on your screen. Thank you.